So I have a microphone. Nina, do you think you could help with the mic around the room? There's one on the table up here. Okay, so who wants to be first? Who's brave? I pushed a button. I'm sorry. You can't trust me.
No worries.
All right.
Leia, I have a question. You mentioned that with the blood vessel blockers, that there was some evidence that they improved hearing. How did that work? I don't understand how that functions.
It's actually a very, very good question, and we honestly don't know. There are a lot of different theories. It's actually being tested at some research lab, one of which is at UCLA with Dr. Marco Giovannini. We are testing that. There are various theories. Is one, it could be kind of a compressive effect of the tumor onto the nerve. And by doing that, it actually is causing a lot of kind of fluid buildup when there's a lot of blood vessels growth. And so when we block blood vessels, that can help that. The other theory, though, is that it's maybe intrinsic to the growth factors, that maybe the tumors is allowing a lot of growth factors in, and that then affect the nerve and affect hearing, because we know you can have very small tumors and can still have hearing loss, right? So it's not all a swelling or compressive effect. So we don't know for sure which mechanism, or it could be a combination of both possibly, but it works, and that's so far what we're banking on.
I'll operate this microphone, but I might as well get all my questions out of the way at once. Somewhere along the line, I don't know if it was Scott who mentioned it, that radiation treatment can make surgical procedures more difficult. Can you give me a little bit more insight into why not?
I think that the radiation tends to cut down on blood vessels going to the tumor. We know if we give a very high dose of radiation, we can kill the tumors, but it also kills the nerves that we want to save that are around the tumor. So rather than giving 22 gray, which is a measure of radiation that will kill the tumor cells, we give about 12 gray because we think that slows them or stops them. And most likely it's blood vessels going into the tumor that are stopped with a lower dose. The reason that we think that it's more difficult to save some of the nerves around the tumor, like the facial nerve, after radiation is probably similar. The blood supply is not as good after radiation. Also, we find that sometimes the facial nerve will be stuck on the tumor and be more difficult to get off. And often we'll leave a little bit of tumor or capsule to try to preserve the facial nerve when we're taking facial nerve off of a tumor that's been radiated.
You think about scar tissue?
Scarring or yeah, I think that's a good term for it, scar tissue or fibrosis or something that we kind of feel like the radiation fuses the tumor and the nerves together, the ones we're trying to separate from the tumor.
So is radiation a kind of a one and done per tumor?
Yeah, we don't usually give them more. Sometimes I've seen that, but it's rare. Most of the time it's one and done.
And my last question, sorry to the biggest problem I saw with these experimental drugs with my wife was the side effects. How do you gauge, is that improving as these technologies evolve, or as these chemotherapy technologies evolve? And how do you gauge them, and what percentage of the focus do you give to that aspect of quality of life?
So actually, I'll leave the quality of life question actually to the end to ask Dr. Merker to answer that, actually, because that's built in to the trials. But certainly one thing we often do is we do try and use drugs that have been tested for other cancers first, so that we know it really well and know the side effects very, very well, and also how to control the side effects as much as we can. I think it's a very good question for, you know, unlike treating cancers where tumors are growing quickly, you know, for patients with NF2 schwannomatosis, we want to minimize side effects as much as possible. So that's likely one reason is we try and not use drugs that we don't understand first. And we actually do follow very, very closely all the side effects that's built into all clinical trials. That's actually a little different than using things off label, right? When we use off label, that's just a clinical setting. And so you only follow when you're being seen in a doctor's office. So versus a clinical trial, it is built into the clinical trial. We have to see, or at least call patients or doing some sort of evaluations on a regular basis to really follow for the side effects. Then you want to talk about the quality of life study?
Yeah, I think we know for NF and these lifelong, benign disorders that people are not going to tolerate the same side effects that cancer drugs were. And, when we were borrowing a lot of these cancer medications where the risk was you might die in the next 6 months, people will tolerate a lot. But if you're going to be taking this for the next 5, 10, 20 years, you just can't have a good quality of life for that. So we're really trying to focus in on understanding what people want out of their quality of life and how drugs are affecting it. I'm actually super happy to be doing these qualitative interviews with patients. So I've actually interviewed folks who are on the Intuit NF2 trial. First, some of the folks who were taking brigatinib, and now people who are taking neratinib, to ask them that question. So for those of you who don't know, qualitative interview is literally an hour that we sit down and talk over Zoom about what are your symptoms? How are things changing? How worthwhile is this to you? What is it that would make you want to stop? And I can say kind of in our preliminary findings that a big thing that might make people not willing to tolerate these drugs is when it really impacts their kind of social life. Like, can you go to work or school still if that's something you were doing? Can you go out hiking with your friends or, to a restaurant? And if you have side effects, like, for example, I talked to someone who had extremely bad diarrhea and couldn't really, wasn't comfortable going out socially at that was, like, that's not something I'm going to do. So it's definitely can be an individual decision of what makes sense for you and whatnot, but we're definitely trying to focus more on what is the balance that people want, what's the benefit that would be worth it, and what's not, so that we can tailor that a little bit better. And I'll give a plug actually here for the RAINS, the RAINS, which is the Response Evaluation in Neurofibromatosis and Schwannomatosis Collaboration, which Scott is the founder of, and I'm the leader of the patient representative group. We actually have a whole program of patients and family members who help give input on clinical trial design and outcome measures to make sure that we are measuring things that matter to patients. So if that's something that you might be interested in participating in, please come reach out to me. That's a way in which we're trying to proactively affect the design of trials to make them something that's easier to participate in and hopefully improve people's quality of life.
And I would also just say that many of us who see patients in the clinic are involved in research and meet with the researchers in the lab. And when they have a couple of promising drugs, we think really hard about, well, which one of these may be most tolerated in the clinic, and try to bring that back so that we have very early on the input from patients and families and sort of the proactive thought about how best to help patients with all the drug possibilities that come up.
Now, the only thing I would add is that in the big picture, if you look at the perspective over 30 years, we've moved away from what we call traditional chemotherapy, where people's hair fell out, they had heart failure, they got fatal infections. These new medicines that Dr. Nghiemphu is describing, the molecular medicines, have avoided many of those side effects. The problem is the side effects that are most commonly associated with this new generation of medicines hit us where it hurts: fatigue, nausea, constipation, and diarrhea. We've traded it. When this revolution started in 2001 with the introduction of a medicine called Gleevec, we were so delighted that we moved away from these potentially fatal side effects. We underestimated, quite frankly, how hard it is to stay on these medicines that affect nothing that affects your survivability, but affects whether you're willing to take medicines. And so it's a major problem. The other piece of, if we can call that good news, I'm not sure that's good news, but at least it's not fatal side effects. The other bit of good news, I think, has been in my mind, clear signal that we can treat patients with less medicine if they have NF1 or NF2 than if they have cancer. And many of us here are focused on what's the minimum dose that we can give somebody and still be effective. That's some of the data that Dr. Nghiemphu was referencing. So my hope is as we identify these active medicines, once they're identified, the next phase of our research is how do we make it better? How do we lower the dose? How do we do intermittent dosing? Sometimes you're getting medicine, sometimes you're not.
You have a question, sir?
He asked my question.
Great minds think alike.
I was reading over his shoulder.
My question is, one of the drugs that you all talked about was something that I guess shrank tumors or tried to stop the growth. At what point do you, what are some of the deciding factors to go on to starting these drugs to stop or shrink tumors?
So what are the things we look to start the medicines? I think 50% of the time, or 50% of my thinking is focused on the growth trajectory of how big a tumor is. And I emphasize that for those individuals who I get to see in clinic, we often will look at what we call the tumor volumetrics, which is our best guess at the precise size of a tumor. But we try not to focus overly on any single one measurement. Is it a little bit bigger, a little bit smaller? So we look at the trajectory, scan after scan, is it growing? If the answer is yes, that individual I'm thinking about, is this something that they might need treatment in the next year or in 5 years? So that's kind of the growth pattern. And the other one, 50% of my thinking is on a symptom. How's the hearing doing? How's the walking doing? Bowel and bladder function. And I think the older I get, and I say this a lot, the older I get, the more I focus on the symptoms rather than the MRI scan, which is in some ways good, but in some ways frustrating for patients and families, because the easiest thing to focus on is the MRI. But I really do value how people feel and how they're performing in the neurological examination. So it has to be, I guess the last comment would be, every person who walks through our doors is an individual. And that's good in the sense our goal as physicians and nurses and care providers is to individualize our care for the person sitting in front of us. But it does make it hard to convey a one size fits all, I start treatment with X, Y, and Z. So I know it's frustrating not to get great answers out of us on exactly when we treat. On the other hand, I would say that the people who are here now, Children's Hospital, UCLA, Mass General, have a ton of experience with individuals and really do our best to individualize it.
I think the other aspect that I would just point out is some of the therapies that we use can only be used for so long. And so sometimes it's about sort of future thinking. When's the right time to start something that you may eventually have to stop because of the cumulative toxicity? And that's another piece that I take into account.
Yeah, so I think to add on to that, actually, for instance, bevacizumab, which I discussed, block blood vessels. One of its side effects is it stop healing, especially if patients undergo a surgery, for instance. So, we also take into account a patient's just life, what they're planning to do the next year. Are they planning to have any more surgeries on anything else on their body before we would start Bev? Or if they are going to in a trial that may cause diarrhea, sometime we talk about, are you having a big event coming up? So actually, this is one disease where I think every one of us have to spend time and really individualize it to the patient before we make that decision.
One of the unfortunate things is we don't always agree, and we all have different timetables about different things. And maybe the biggest thing we run into is when to initiate a medical trial or a surgical intervention. And sometimes we don't agree at all on that. And it makes it very difficult for patients then to say, well, I've just heard all the experts and they don't know what they're doing. So it's very difficult, very difficult.
But I just want to assure you, many of our groups, including our group here, and on this Monday afternoon at 4 p.m., we have a consensus meeting where we talk about this. We can't guarantee you we're going to agree, and I don't think you want us to. We don't want any rubber stamps. We in all good faith, argue our best medical experience, and there's very many experienced people. Sometimes we just don't know. We all wish we had crystal balls, and I know you want that more than we do. So that's important. I guess the last thing that I want to emphasize on this section is just to say that all of our groups here are absolutely committed to finding treatments for our younger patients. I can tell you, we talk a lot with drug companies, and we are adamant that they allow us to treat individuals as young as 12. We can debate on the actual age, but the idea being that we're taking drugs like bergatinib, which have never been studied in children before, and we basically say, we're not going to do this unless you allow us to treat young kids. And so we're very focused on accessing, these treatments for individuals who, we always say in pediatrics, kids are not little adults. So I want to respect that. And yet on the other hand, none of us are going to wait till every drug has gone through adult trials to allow kids on. So that's another big focus across all of our centers.
I have a question. Sorry.
It's okay.
Excuse me. Can I ask this question? Is there anything naturally you could recommend to do or take to maybe shrink the tumor a little bit? I know that it seems like it's a lot of trial and error with the medications and stuff, but I was just wondering if there's anything naturally over the counter you might be able to take.
We've looked at a number of different naturally occurring elements, and I think sometimes people feel that if it's a drug, if it's something that occurs in nature, it's better for you than something that is made in a lab. That may or may not be true. There are a lot of drugs that come from naturally occurring elements, and when we reviewed 20 of the most common elements that people were using to control these tumors, and we didn't find very many of them that got absorbed into the bloodstream in high enough quantities to be measurable or likely to help. In the lab, we've looked at a number of them, and some of them do have activity against the tumors. Resveratrol is one of them that comes in broccoli, I think. There's one in red wines, yeah. And beeswax. Beeswax have a number of different elements, but it's also difficult when you're taking something over the counter to know what the exact ingredients are. There'll be 100 different compounds in something you take that's extracted from beeswax, and one of them may potentially be helpful if it got to the level in the bloodstream to be therapeutic. So it becomes very difficult when it's not a drug that's regulated by the FDA to know exactly what you're getting. And I can say that even though we've published a few papers about some of these naturally occurring elements, that I don't have any current confidence that any of them have really good data to show they help. Is that fair?
Yeah, I agree. Sharon, I think you had a question.
Yeah, so two questions. So you mentioned Gleevec, and I'm curious if you've looked at other targeted, repurposing other targeted cancer drugs. And then the second part is, if you have you looked at the data for quality of life that cancer patients face when they're taking those drugs?
We've looked at a gazillion, I think would be the term, repurposed drugs. They're the National Center for the Advancement of Translational Science, NCATS, which is a huge part of the NIH, participated with a Children's Tumor Foundation sponsored program called Synodos for NF2. And we took a huge number of compounds through the NCATS pathway. And actually, bergatinib popped up from that. So we had no idea beforehand. And there's a lot of reasons why we never would have chosen bergatinib. So the answer is yes. We've looked at a bunch of them. People like Marco Giovannini, who works with Dr. Nghiemphu here, has put many, and Leia Shu, who's in our program here, and many others around the world, will take the ones that get screened in a cell assay. That means in a dish. Whatever looks interesting there, it gets brought into a more representative model, whether it's mice or other organisms. And then what we do here is that we say, okay, whatever makes it through that pipeline, we would consider, requesting funding to run a human clinical trial. we think very, to back up what Dr. Jordan said, we think very carefully, if we have a palette of choices, what's the most tolerable? And there are some medicines that looked good in a dish that we do not believe, based on our experience with other patients, should move forward, and we haven't pursued those. I don't know if that's the right answer. You want to add to that?
No, I think that's great. Thank you. There was a
I just have one question, Dr. Plotkin. You referred to tumor growth causing bowel and bladder problems, and that sort of caught my ear as new information to me, at least. And then you were talking about the molecular therapies also causing, bowel difficulties. So you could just say a little bit more.
Sure. So I guess I would go back to the first principle that any condition that affects nerves can cause all the problems you're talking about. So we think in terms of what we call the central nervous system would be the brain and spinal cord. And then we think of the nerves as being what we call the peripheral nervous system, the ones that come out of the spinal cord. And I think you can get bowel and bladder troubles from both of those. I would say the ones that I see quite commonly could be any kind of compression of the spinal cord. That we use the term myelopathy would be one reason somebody could begin to experience bowel and bladder troubles. Usually it's not being able to hold your bowel and bladder, but occasionally it's retention or not being able to completely evacuate. The other way is some people can have tumors on the nerves that leave the spinal cord and go to innervate or go to the bowel or the bladder, most commonly the bladder. And then occasionally individuals can have tumors actually in the pelvis that can cause local compression, other problems. So I would just say that those symptoms, when they're related to the schwannomatosis or the NF1 for that matter, working with an experienced neurologist to localize the problem is step one, right? So you want to know where is the problem. That's what our specialty is. In terms of drugs, this has to do with the proteins that get blocked, and is usually a completely different issue, not related to nerves, but related to the actual compounds that are being inhibited by the drug. So there are two different mechanisms. Would you agree with that?
And so the bowel issues that's related to these compounds is actually, if you remember when I talk about the receptor tyrosine kinases, is tend to block something called the epidermal growth factor receptor. So our bowels actually, a lot of our bodies no longer have growing cells, so hair being one, although that doesn't affect us much, but the bowels, actually the cells do cycle and regrow because as we eat and move our bowels, those cells get sloughed off. So these drugs blocks pathways that inhibits those growth. So that's why it's actually more of a mechanism directly related to the compound rather than the tumor effect on the nervous system.
Can I ask one more question on that follow-up? And I'm sorry. So my NF2, it's so food sensitive that when I go out for a cup of coffee and I ask for a decaf coffee, and if they gave me a caffeine and I take a sip of it, I can feel it like hit something in my brain right away. And I gotta believe that that's my tumor. And I can push it back and say, that's not decaf. And they'll say, oh, sure, you're right. And that's happened many a times for me. Ketchup, some sodium. And I'm just wondering, is any of the NF2 food related? And that's why I asked the question, anything natural? Because if I was to have a regular cup of caffeine coffee, I got a headache for a couple of hours.
I think that it's difficult to separate the effect of your tumor on the brain from the effect of the caffeine. I think there are many people who have headaches affected by caffeine without any tumors. And so the fact that you have an association and you do have tumors, you may relate it to the tumors, and maybe it is, but I don't think we have any good evidence to say that it's highly related. People who suffer from tinnitus or ringing in the ears, caffeine can affect that as well without any tumors. And so it's headaches and ringing in the ears are such common symptoms for many things. And caffeine certainly affects those, whether that's tumor related or not, it's very difficult to say.
Yeah, that was one of the reasons I met up with Dr. Jordan, because I was getting the headaches from the food, and I didn't think it was much, but when they did the MRI, that's what they found. So that's
Migraine headaches are very sensitive to a number of different foods, wines, cheeses, different things, and caffeine.
Absolutely,
And so maybe you have some migraine. That's up to Dr. Jordan to help with her.
Get a real doc.
All right, other questions? Okay.
I think with gene therapy, and maybe this is just your crystal ball, but I think the thought process is we're all hoping it would help early on with tumors, but is there any thought process would it be able to treat or reverse anything that's existing? Is that a thought as well?
I agree that was our thinking, and is probably the current thinking, that gene therapy would be more effective at stopping tumors from growing than reversing tumors that were already in place, for a number of technical reasons. However, in one mouse model we have where we injected the gene into the tumors regressed, and it surprised me a little, and even some of the naturally occurring neural elements seem to come back, and I thought that's really strange. So I didn't ever believe that Scott could reverse hearing loss with bevacizumab either, and I was wrong. So I don't know. We'll see. But yeah, I think that's a good question.
I think that partially that may go back to the route of delivery, you know, as Scott sort of talked about. Do we do it in people who are early in their disease course who have mild disease? Do we do it in late people who have severe disease and perhaps less options? But some of the other discussions that we've had is, you know, do you give it directly within the tumor? There are instances like with spinal muscular atrophy where they give it into the spinal fluid so that it sort of goes to the entire nervous system, the central nervous system. That doesn't get to the peripheral nerves. So I think there are sort of a lot of different approaches, as Scott outlined with his bridges analogy, to the various ways that you can think about using gene therapy. And sometimes it comes to a mouse and you figure out, does this particular virus with this particular gene therapy shrink tumors, stabilize tumors? And then you think, okay, well, how do I apply that to a patient in the safest way possible, but also the most beneficial way possible?
The only thing I'll add, it doesn't matter in the sense that we're going ahead with this no matter what. You know, I mean, a home run for us would be to shrink the tumors, and maybe a triple is to prevent them, or maybe that's not the right analogy. But I will alert you to one thing in the back of your head. Remember that persons with NF1 and schwannomatosis are born with one abnormal copy. And so what I point out to all the people who ask that question, we don't know what does it mean when you have one normal copy, one abnormal copy in your white blood cells. Your immune system controls tumor. We all probably have, if you get as old as I am, a tiny tumor in your body somewhere that's lying dormant. That's what the data suggests. And our immune systems control this. How do we know this? We know that people who get HIV, when their immune system drops because of HIV, they're at high risk for cancers, in addition to infections. So our immune system plays a part. So is it possible that tumors could shrink when we replace the gene? Well, don't forget, we're going to replace it in some cases in the white blood cells as well, the immune system. So we can't limit ourselves, is I guess the point, because we really don't know. And that's why we're really committed to moving this forward, because I think there's going to be a lot to be learned here. One thing we know, the cancer world doesn't predict exactly how things work for persons with NF1 and schwannomatosis.
All right,